Welcome, everybody. In this video, I will talk to you about the echocardiographic features of pericardial effusions and tamponade. First, I'll go through the anatomy of the pericardium and then introduce the topic. Then I will discuss tamponade physiology and the echocardiographic features of tamponade physiology. Then I will go through the differentiation between circumferential pericardial effusions causing tamponade and regional tamponade. And then I will discuss the management of pericardial effusions and tamponade. Let's start off with the anatomy. So the pericardium is composed of two layers. The outer layer is called the fibrous pericardium. The fibrous pericardium is about 1 to 2 millimeters thick, and it's inelastic. The inner layer, on the other hand, is called the serous pericardium. And the serous pericardium is composed of two layers: the parietal pericardium, which is the outer layer, and this is adjacent and adherent to the fibrous pericardium. And then the inner layer is called the visceral pericardium, and this overlies the heart, and we call this the epicardium. Normally, the serous pericardium holds a little bit of fluid, up to a maximum of 50 milliliters of fluid at the most. There are certain folds in the pericardium, which we call sinuses. These are reflections of the pericardium overlying certain structures. And there are two important sinuses that we need to be aware of. The first is the transverse pericardial sinus, which is a fold of the pericardium right behind and posterior to the great vessels, the aorta, and the main pulmonary artery. And the other sinus that we need to be aware of is called the oblique pericardial sinus. And this is a reflection of the pericardium at the back of the heart, between the insertion points of the pulmonary veins into the left atrium. Now here we see two parasternal long axis views. In the first image to the left, we see a fluid collection in the far field that is adjacent to the heart. In the image to the right, we see another fluid collection that is also adjacent to the heart. It's important to make a distinction between both fluid collections. The one on the left here is a pericardial effusion, and the one on the right is a left pleural effusion. Now, how do you distinguish between a pericardial effusion and a left pleural effusion? When you look at the pericardial fluid, it usually tracks anterior to the descending thoracic aorta. And you can see here that the fluid has an extension anterior to the descending thoracic aorta between the aorta and the left atrium. This fluid here is tracking up in the oblique pericardial sinus. On the other hand, left pleural effusions track posterior to the descending thoracic aorta. You do not see an extension of the fluid anterior to the aorta. It all tracks posterior. There are multiple causes for pericardial effusions. The common ones that you will see include intrathoracic malignancies, especially lung cancers. These tend to cause malignant pericardial effusions. You'll also see in chronic renal failure patients uremic pericardial effusions. Trauma can give you a pericardial effusion, and that's why we check in the extended FAST scan the subcostal four-chamber view to assess for a traumatic pericardial effusion. Post-myocardial infarction, you can get free wall rupture and a pericardial effusion. With volume overload and cases of anasarca, secondary to congestive heart failure and liver cirrhosis, you can get accumulation of fluid in the pericardium. Post-surgical, after cardiac surgery, or iatrogenic causes can also lead to pericardial effusion. For example, perforating the atrium in the EP lab can give you a pericardial effusion or a hemopericardium. There are pericardial effusions that will be idiopathic with no real cause. Myxedema, radiation therapy, autoimmune diseases, and some infections, viral and bacterial, can give you pericardial effusions as well. There is a way to quantify how much pericardial fluid exists. If you measure the pericardial fluid diameter in end diastole, it will give you an idea of how much pericardial fluid there is. If you see a pericardial effusion that is less than 1 centimeter in diameter, and it is only visible in systole, during diastole, it is not visible, then this means that you likely have less than 50 milliliters of pericardial volume. If you see a pericardial effusion that is less than 1 centimeter in diameter, but it is visible in both systole and diastole, this means that the pericardial fluid is roughly in the range of 50 to 100 mils. If the pericardial effusion diameter is greater than 1 centimeter, but less than 2 centimeters, then the pericardial volume of fluid is likely between 100 to 500 mils. If the pericardial fluid diameter is greater than 20 millimeters or 2 centimeters, this indicates a pericardial effusion of greater than 500 mils of volume. So let's look at the image up the top, on the top here, where we can see that there is a pericardial effusion, that it is visible in both systole and diastole. It does not disappear during diastole, and it's likely less than 1 centimeter in diameter. And so what we're looking at here is a mild pericardial effusion. We're expecting about 50 to 100 mils of pericardial volume. On the other hand, in this parasternal short axis view, you see a very big pericardial effusion that is circumferential. It is more than 2 centimeters in diameter. And so this is a severe pericardial effusion. We're expecting more than 500 mils of pericardial volume. Now, it's important to distinguish pericardial effusions from epicardial fat pads. An epicardial fat pad will be visible mostly anteriorly. It will be absent posteriorly. It will not track posterior to the heart. You will see that the pericardial motion is normal. It's not affected by the epicardial fat pad. And you will see that the epicardial fat pad itself looks a little bit like tissue. There are tissue planes in it. We call these faint linear striations or low intensity echoes. And so unlike pericardial fluid, which will look like an anechoic stripe, here this will look slightly hypoechoic and it will look more tissue-like. You also need to distinguish pericardial effusions from pericardial cysts. Pericardial cysts are usually loculated, and usually they have no communication with the left ventricle. When you look at left ventricular pseudoaneurysms, on the other hand, these usually communicate with the left ventricle. By definition, a pseudoaneurysm is a contained rupture of the ventricle. On echocardiography, it will have a narrow neck. And so here we see a left ventricular pseudoaneurysm that communicates with the left ventricle. It has a narrow neck between the mitral and the aortic valves and the mitral aortic curtain in this TE image. You also need to distinguish pleural effusions from pericardial effusions, and we went through the differentiation earlier. Let's go through tamponade physiology. Now, one thing that is important to recognize is that the rate of accumulation of pericardial fluid is extremely important in determining whether the patient develops tamponade or not. If you have a pericardial effusion that accumulates very rapidly, you may develop pericardial tamponade with very little volumes. As little as 150 to 250 mils can give you tamponade if the pericardial fluid accumulates quickly. And this we usually see in iatrogenic pericardial effusions, post-surgical, traumatic pericardial effusions, in cases of aortic dissection, and in cases of post-MI free wall rupture. On the other hand, if the pericardial fluid accumulates slowly over time, this allows for the pericardium to slowly stretch over time. And you can accumulate a large volume of pericardial effusion, up to 1 to 2 liters of pericardial fluid, before you start exhibiting features of tamponade. And we see these slowly accumulating effusions in cases of malignancy, chronic renal failure, and uremic pericardial effusions, and in idiopathic pericardial effusions. Now, the intrapericardial pressure normally tracks the intrathoracic pressure. And it normally fluctuates anywhere from -4 to +4 millimeters mercury. Normally, the intrapericardial pressure is much lower than the left ventricular end diastolic pressure and the right ventricular end diastolic pressure. However, in cases of tamponade, the pressure will build up in the pericardium, and the intrapericardial pressure may reach as high as 15 to 20 millimeters mercury. This high intrapericardial pressure may overcome the diastolic chamber pressures and lead to a transmission of this intrapericardial pressure to the different chambers of the heart during diastole. And so what you will sometimes see in circumferential pericardial effusions causing tamponade is that the pericardial fluid pressure is being transmitted to all the cardiac chambers during diastole. And so you'll see an elevation of end diastolic pressures, and you'll see an equalization of end diastolic pressures because all the chamber pressures now are reflecting the intrapercardial pressure. And so you'll see an equalization of the end diastolic pressure of the right atrium, right ventricular end diastolic pressure, of the pulmonary capillary wedge pressure, and the left ventricular end diastolic pressure, in addition to pulmonary artery diastolic pressure. And so all of these will be elevated and equalized in cases of pericardial effusions giving you tamponade. Now, as pericardial fluid accumulates, the intrapercardial pressure will increase. This will lead to a compression of the cardiac chambers, and this will lead to diminished diastolic filling of the cardiac chambers. And you will see that when you look at the CVP tracing, you will lose the Y descent because of the diminished diastolic filling. Then you start getting reduced cardiac output because of reduced filling, which leads to insufficient systemic and quantiferous perfusion. And if you're not able to break that cycle early on, you will spiral into a cardiac arrest, usually a PEA cardiac arrest. The classic features of tamponade we've all heard of: the muffled heart sounds, the elevated JVP, the hypotension and the shock, the tachycardia, the narrowed pulse pressure. But I want to focus on Pulsus paradoxus, because Pulsus paradoxus is a very important feature of tamponade. What is Pulsus paradoxus? It is a drop in systolic blood pressure by more than 10 millimeters mercury during inspiration. Normally, during inspiration, your systolic pressure drops slightly, but it usually does not drop by more than 10 millimeters mercury. If it drops by more than 10 millimeters mercury, this is called Pulsus paradoxus. So Pulsus paradoxus is nothing other than an exaggeration of a normal phenomenon that we see during normal breathing. Why do we get Pulsus paradoxus? It's essentially because of pericardial constraint. So what ends up happening, if you have somebody who's spontaneously breathing and they take in a breath, during inspiration, you'll get negative intrathoracic pressure, you'll get an increase in venous return, you'll get an increase in right heart filling. During inspiration, because of the negative intrathoracic pressure, you will accumulate blood in the lungs and you'll get a reduction in left heart filling. And because the right heart is filling more than the left heart during inspiration, you'll get a shift of the septum to the left. Now you have a big pericardial effusion, there's a lot of pericardial constraint, so the right ventricle has nowhere to go other than shift the septum over to the left as it accommodates all this blood. With this septal shift to the left, you'll get a reduction in left ventricular stroke volume, and you'll get a reduction in the pulse amplitude and a drop in systolic blood pressure during inspiration. Why does it happen? It's because of the pericardial constraint giving you the ventricular interdependence. Now the septum is the only way to accommodate blood in each of the chambers. During expiration, on the other hand, you get a reduction in venous return, you get a reduction in right heart filling, you get blood moving out of the lungs and back into the left heart. And so as the left heart fills and the right ventricle starts accepting less and less blood, you get a septal shift over to the right. And with that septal shift to the right, you get an increase in left ventricular stroke volume and an increase in pulse amplitude. And so this septal movement back and forth is what we see on echo in cases of tamponade, and we call it a respiraphasic septal shift or a septal bounce. These are the echo features of tamponade, and we'll go through them one by one right now. We'll first need to be able to demonstrate that we can see a pericardial effusion that is at least moderate, if not severe. So it has to be at least greater than 1 centimeter in diameter, and it's reproducible in multiple views. We can see it here in the subcostal forechamber, and we can also see it in the parasternal short axis. One of the echo features of tamponade that is extremely important is right atrial late diastolic collapse. This is a very sensitive and very early feature of tamponade. So why does the right atrium collapse in late diastole? It collapses in late diastole because that is the point in the cardiac cycle where the chamber pressure, the right atrial pressure, is the lowest at the end of diastole when it's emptied out all the blood in the right ventricle, the pressure inside the chamber is the lowest in late diastole. And so the intrapercardial pressure overcomes the right atrial pressure in late diastole. It's an early marker of increased intrapercardial pressure. It's 100% sensitive for tamponade. However, its specificity is only about 82%. The specificity does improve if the compression of the right atrium is longer. The longer the right atrial collapse, the more severe the tamponade. And it becomes more and more specific if you have collapse of the right atrium in more than 30% of the cardiac cycle. We can see here in this apical four-chamber view that the right atrial free wall flattens out and even becomes introverted during diastole. Now, normally, the right atrial free wall is convex outward. It's not normally flat, and it's not normally concave. And we see here that it becomes concave and inverts during part of the cardiac cycle. This is a very early and sensitive feature of pericardial tamponade. The second feature of pericardial tamponade is right ventricular early diastolic collapse. This is a very specific finding for tamponade. It's 100% specific. When you see right ventricular diastolic collapse, it is 100% specific for tamponade. Sensitivity is only 92%. Now, the collapse happens in early diastole because the intracardiac pressure in early diastole for the right ventricle is the lowest it can be at that time point in the cardiac cycle. And so the chamber will only collapse during the point in the cardiac cycle where the intracardiac pressure is the lowest and the intrapercardial pressure can overcome the intracardiac pressure. And so that tends to be an early diastole for the right ventricle. We can see it usually in 2D mode. You can see here there is an inversion of the right atrial free wall. And if we do M mode, we will see here that the right ventricular free wall is collapsing during diastole. Elevated right ventricular pressure at baseline, like in patients with pulmonary hypertension or severe tricuspid regurgitation, can prevent the right ventricle from collapsing. Another echo feature of tamponade is the exaggerated respiraphasic variation of transvalvular Doppler flow velocities, which means the left ventricle filling velocity, or the mitral E wave, will have a lot of variation with respiration. Similarly, the tricuspid E wave will also have exaggerated variation with respiration. Now, the cutoff for the mitral E wave variation is greater than or equal to 30%. The tricuspid E wave variation is greater than or equal to 60%. Now, this respiraphasic variation in ventricular filling is just a manifestation of Pulsus paradoxus on echocardiography. As the patient breathes in, the right ventricle fills, and the left ventricle filling diminishes. And as the patient breathes out, the left ventricle fills. And so you see this exaggeration in variability of filling on the mitral E wave and the tricuspid E wave. I must say, however, that this is not specific for tamponade. We can see Pulsus paradoxus in other conditions that we will go through later. You will see this variation in filling in patients with atrial fibrillation because they usually have variable filling times. And so this is not a valid sign in patients with atrial fibrillation. This exaggerated respiraphasic variation in mitral and tricuspid E wave velocities is usually blunted or absent in mechanically ventilated patients. Now, obviously, with mechanically ventilated patients, there's positive intrathoracic pressure during inspiration, so the changes are actually reversed. But not only are they reversed, they're also blunted and sometimes even absent. These variations in left ventricular and right ventricular filling we call the echocardiographic Pulsus paradoxus. Another feature of pericardial tamponade is the respiraphasic intraventricular septal shift, or what we call the septal bounce. The septum moves back and forth between the left and the right side, And this is due to enhanced intraventricular dependence and pericardial constraint from the tamponade. With tamponade, you will also see a resporophasic cardiac output variation, and the cardiac output you can measure by measuring the LVOT VTI. You should also be able to demonstrate that the IVC is plethoric, distended, and has no variation with respiration. This is a very important feature of tamponade, a plethoric, distended IVC that does not vary with respiration. If you put the echo probe on a patient and their IVC is flat and there's a lot of variation with respiration, that rules out tamponade physiology. This patient does not have pericardial tamponade. The IVC must be distended and must have no variation with respiration. Also, the hepatic vein flow patterns can be altered with tamponade. We normally see a systolic predominance in the hepatic vein flow pattern. The systolic wave is greater than the diastolic. This is normal. S is greater than D, or systole is greater than diastole. However, in patients with tamponade, what you may sometimes see is a diastolic flow reversal during expiration. This finding is not really valid in patients with severe TR, because these patients with severe TR sometimes will have systolic flow reversal. Now, there are certain conditions where you can see pulsus paradoxus without the patient having tamponade. The first of these conditions is when the patient is breathing very large tidal volumes or exerting a lot of effort to breathe. Patients in respiratory distress or patients with COPD. You can sometimes see a pulsus paradoxus in patients in respiratory distress just because of the very vigorous respiratory efforts that they are exerting. Another condition where you can see pulsus paradoxus without tamponade is when you have right ventricular dilatation or right ventricular overload or an acute RV infarct. In these conditions, you can get, because of the RV dilatation, you can get pericardial constraint and enhanced ventricular interdependence. And you can sometimes see pulsus paradoxus in these conditions without having tamponade. You can also sometimes get significant pericardial constraint with a tension pneumothorax, in which case you will also see pulsus paradoxus without tamponade. And when I say pulsus paradoxus, I'm talking about clinical pulsus paradoxus and echocardiographic pulsus paradoxus, the exaggerated mitral E wave variation and the tricuspid E wave variation. We call that the echocardiographic pulsus paradoxus. On the other hand, you can sometimes have pericardial tamponade in patients that do not exhibit pulsus paradoxus. And we see this sometimes with regional tamponade. When you have a focal hematoma compressing a certain chamber of the heart, you will develop tamponade without showing echocardiographic or clinical pulsus paradoxus. If the patient is in extreme hypotension, you'll sometimes not see the pulsus paradoxus. If the patient has increased right ventricular filling pressures and right ventricular hypertrophy, or increased left ventricular filling pressures and left ventricular hypertrophy, in both of these conditions, you may develop tamponade without showing pulsus paradoxus. With severe aortic incompetence, you get an increased left ventricular filling pressure. And with atrial septal defects, you will sometimes get increased right ventricular filling pressures. And so in these conditions, you may still develop tamponade without having pulsus paradoxus. And very importantly, in patients who are on positive pressure ventilation, you may still have a patient developing tamponade without exhibiting features of pulsus paradoxus. Here we can see a parasternal long axis view, and we're demonstrating very nicely how the right ventricular free wall is inverting during diastole. And if you put M mode across that right ventricle, you can see here that the right ventricle collapses during diastole. And that right ventricular diastolic collapse is 100% specific for tamponade. In this apical four-chamber view, we see right atrial diastolic collapse. And this is 100% sensitive for tamponade physiology. And then if you measure the mitral inflow by putting pulse wave Doppler on the mitral inflow, the E wave you will see will exhibit a lot of variation. You can see here that the peak E wave velocity is 90 centimeters per second, and it drops as low as 60 centimeters per second. If there's variation of 30% or greater, this is what we call echocardiographic pulsus paradoxus. This is a feature strongly suggestive of tamponade. We see that the IVC is distended, it's plethoric, and there's no variation with respiration. And we see here that the variability is very minimal with respiration. The IVC is distended and non-varying. And so we've gone through all the features of tamponade. You should be able to demonstrate the pericardial effusion circumferentially. It should be at least moderate to severe. You should be able to demonstrate chamber collapse, right atrial late diastolic collapse and right ventricular early diastolic collapse are both very important features. And then a plethoric non-varying IVC, the exaggerated respiraphasic variation of transvalvular Doppler flow velocities of the tricuspid E wave and the mitral E wave, and then the septal bounce or the respiraphasic interventricular septal shift is also a feature of tamponade. Let's go through the differentiation between circumferential and regional tamponade. Circumferential tamponade refers to a pericardial infusion that is encasing the entire heart. And this is pericardial tamponade that we usually see in the medical ICU. However, when you look at early surgical tamponade, these patients usually present differently. These are usually patients fresh after cardiac surgery. They usually have a high chest tube output that all of a sudden stops. The chest tubes now have clotted, and the patient continues to bleed on the inside. And so with that, as they develop a blood clot in the pericardium, this can sometimes give you a regional tamponade and compress a certain chamber of the heart. And you'll start seeing an increase in CVP, right atrial filling pressure, and left atrial filling pressure manifested as an increase in pulmonary capillary wedge pressure. You'll see that an increase in pressor requirements in these patients. They'll start developing shock, like low urine output, increased lactate, cold shutdown periphery. However, the art-line pulsus paradoxus may or may not be present. You may not see it because these patients are usually on positive pressure ventilation in the fresh post-op period. Early post-cardiac surgery tamponade is usually regional. It's usually due to an organizing coagulum or a blood clot, a localized hematoma that's compressing a certain cardiac chamber. It's usually not circumferential, it's usually localized. And as I said, certain features of tamponade you may not be able to demonstrate. They may not have pulsus paradoxus, or it may be attenuated or even absent. They may not have the diastolic pressure equalization. They may not have the right atrial, right ventricular diastolic collapse. Depending on where the hematoma is, it can compress any chamber of the heart. This is a TE image of a post-op patient who developed tamponade. And you can see here, this is the right atrium, this is the right ventricle. You can see that there is a huge blood clot outside of the right ventricle, compressing the right ventricle and limiting right ventricular filling. And when you rotate the probe more towards the right side of the patient, you can demonstrate that this huge hematoma is really compressing the right ventricle and giving you a regional tamponade. After evacuation of this hematoma, you can see here that the right ventricle can now fill more easily. How do we manage pericardial effusions in tamponade? Well, if you find a pericardial effusion and it looks small, and it's an incidental finding, then you can just observe and potentially even repeat the study later down the road for follow-up. If you have a patient who has a pericardial effusion that is exhibiting tamponade physiology and the patient is unstable, then you need to temporize the hemodynamics as much as possible by giving fluids, by giving pressors, and do a stat cardiology consult. Call the cardiologist for a stat percardiocentesis. And as you're waiting for them to arrive, you should have the percardiocentesis kit at the bedside, just in case this patient collapses. If the patient collapses, it will need to be done emergently. The percardiocentesis kit needs to be ready right then and there as you're waiting for cardiology to arrive. If the patient collapses and you end up doing CPR and they've got a very large pericardial effusion, then they will need an emergent percardiocentesis. The most senior clinician in the room needs to do the percardiocentesis right then and there, or else you will not be able to attain return of spontaneous circulation. That pericardial effusion needs to be drained. And that's why the percardiocentesis kit has to be at the bedside in unstable patients, just in case they crash. The pericardial fluid will need to be drained emergently. So let's summarize what we've gone through. Tamponade does remain a clinical diagnosis. The patient must exhibit features of shock for you to be able to make the diagnosis of tamponade. The echocardiographic features of tamponade include right atrial late diastolic collapse, and this is the most sensitive echo finding, and it is the most early echocardiographic finding of increased intrapercardial pressure. It is 100% sensitive for pericardial tamponade. Right ventricular early diastolic collapse is the most specific echo finding for tamponade. It is actually 100% specific. The IVC must be plethoric, distended, and non-collapsible. If you put the echo and you find that the IVC is small and collapsible, this rules out tamponade physiology. Regional tamponade, especially in the post-cardiac surgery patients, may not have the classic echo features. You may not see a circumferential pericardial effusion. You may only see a clot compressing a certain chamber of the heart. In critically unstable patients with large pericardial effusions and tamponade physiology, you should call cardiology to drain it because they are the experts in percardiocentesis. However, you should always have the percardiocentesis kit at the bedside just in case this patient crashes. Thank you very much, and we'll move on to the next video.